Hello, my name is Elizabeth Medhurst and I'm a nurse consultant who works as a part of the Prostate Theranostics Imaging Centre of Excellence, embedded within the Nuclear Medicine Department at MacCallum Cancer Centre. Today, I'm here presenting on behalf of my co-authors our single centre experience of treating men with metastatic castration-resistant prostate cancer with Lutetium-177 PSMA-I&T using a TheraP-like algorithm. Over the past 12 months, we have been presented with high-level prospective data supporting the use of lutetium PSMA in men with metastatic castrate-resistant prostate cancer. Both the VISION and TheraP trials show treatment efficacy and safety in a third-line setting. However, this is with the use of lutetium PSMA-617. High-level prospective data remains scarce in the use of PSMA-I&T. But what do we know? Lutetium PSMA-I&T shares a similar biological targeting complex to lutetium PSMA-617. The targeting motif is identical, and the chanteler is DOTA-TAGR rather than DOTA. It has been subject to robust validation, including cell binding kinetics, animal models, and in-human use since 2013 and 14 in Germany. Radiation dosimetry data also suggests organ and tumour absorbed doses are radial equivalent. And with this in mind, our question was, are we able to produce comparable results with I&T in a similar cohort of patients? Our key inclusion criteria included ongoing treatment with ADT, prior exposure to at least one line of chemotherapy or assessed as medically unfit, progression or intolerance to a novel anti-androgen therapy, adequate hematological, renal, and hepatic functions, an SUV max greater than 15 on PSMA PET, and no FDG discordance. From September 2020 to May 2021, there was a total of 65 patients screened. 46 were deemed eligible and 19 ineligible, and this is mainly due to the imaging criteria alone. And this is not too dissimilar to the TheraP study, which found 30% of men to be deemed ineligible. The majority of our patients had received 3 or 4 lines of treatment. There was an 8% crossover of patients who received both enzalutamide and abiraterone, and 9% of patients who received other treatments as well, and this included clinical trials. Baseline characteristics were not too dissimilar to the TheraP study, although there was a higher median Gleason score and a higher median PSA at 158.5 compared to 93.5. Once screening was completed, patients were treated every 6 weeks up to 6 cycles. Patients received a starting dose of 8.5 gigabecquerels, decreasing by 0.5 gigabecquerels with each cycle. Patients received their treatment and returned 24 hours post for a SPECT CT and review with a nuclear medicine specialist. Patients completed follow-up bloods at 3 and 5 weeks post-treatment. For the purpose of comparing our results, we have compared to the Phase 2 Blue PSMA trial from Professor Hoffman and co., published in Lancet Oncology in 2018, along with the follow-up paper published in the Journal of Nuclear Medicine in 2020, as well as the recently published TheraP study. Although this is not a perfect comparison, the Phase 2 study is not too dissimilar, as many of these patients were treated in the last line. But when compared to TheraP, who had 1 line of chemotherapy plus or minus a novel anti-androgen therapy, they were treated slightly earlier in the treatment paradigm. Our patients were treated in the last line setting. I will note 12 or 26% of men continued treatment, with the data cut off in January 2022. A median of 3 cycles were received by our patients, and this is due to either exceptional response or disease progression. 1 patient was excluded from the analysis as he had an undetectable PSA at baseline. As you can see, 56% of our patients had a PSA reduction of 50% or more, showcasing the waterfall plot. We do see comparable responses, even in differing patient cohorts and slightly differing eligibility criteria. In terms of PSA progression-free survival, in our cohort, it was 5.3 months, which again compares to TheraP, and it does appear to be slightly shorter than the duration of the Phase 2 study. As noted before, there are still men continuing follow-up in our cohort of patients. This may change with longer-term follow-up. Overall survival was similar again to the Phase 2 study, and the overall survival data from TheraP is yet to be published, so we are unable to compare. I will note there was no treatment-related deaths in our cohort of patients, and 20 patients have died as of January 2022. In terms of toxicities from the treatment, We only evaluated grade 3 and 4 toxicities as per the CT-CAE criteria. Grade 3 anemia was seen in 6.5% of patients, and grade 3 thrombocytopenia in 2.2% of patients. There was no grade 4 toxicities, and there was no other grade 3/4 toxicities attributed to Lu-PSMA. In terms of the strengths and weaknesses of this data, this treatment was given in a real-world setting, and we were able to establish a relatively low side effect profile, even in heavily pretreated men. Weaknesses included that this data was collected retrospectively, we did not collect any quality of life, and it is a relatively small sample size. We only evaluated the grade 3/4 toxicities, and our dosimetry data is yet to be analysed. Just a comment, there is 2 phase 3 prospective trials currently recruiting with Lutetium PSMA-I&T. One is a SPLASH trial for patients who have progressed upon novel anti-androgen therapy and deemed ineligible or refuses chemotherapy. A 2-to-1 design randomizing Lutetium PSMA versus enzalutamide or abiraterone. There is also the ECLIPSE study, which again is a phase 3 prospective trial currently recruiting in a similar fashion. Lutetium PSMA-I&T compared to standard of care hormone treatment. And with all this in mind, in conclusion, treatment efficacy and toxicity with Lutetium PSMA-I&T are comparable to previous experiences with Lutetium PSMA-617, patients deemed suitable following PSMA and FDG PET screening. Thank you.